first of all, I want to point out to you, I don't know if we have a pointer, but Candida species is becoming now the fourth most common cause of bloodstream infections. Like we call it septicemia or bacteremias, whereas the bacteremias, it's becoming the number 4 one. And keep it in mind that in the United States is on the rise, particularly in ICU patients or patients receiving total parenteral nutrition, patients with central venous catheters. Obviously included in this picture are patients whose neutrophil count or white cell count is going downward. The other problem is when Candida gets into the blood, the mortality is very high. The crude mortality is 47%, which is, you find it in the middle, which is like one of the most actually organisms, microorganisms associated with the highest mortality. The second thing is that the attributable mortality of nosocomial Candida has really, the one which is attributable mortality is also one of the highest. And it, based on this slide, ranges between 38% to 49%. Add to all of this a high crude mortality, high attributable mortality, it does prolong the hospital stay significantly. And it also increases the cost. So we have to develop ways of how to prevent it. Who are the high-risk patients for this infection? They are mainly patients with abdominal surgeries. They are patients with low white cell count, we call them leukopenic, and particularly low neutrophil count. And they are mainly burn patients or they are premature infants. This is some of the list. I'll show you a longer list later. But among the other things that you have to keep in mind is this middle column here, is that the exposure, these are patients who have been on the ICU, often you see them for more than 7 days. They have a central venous catheter. Antibiotics, they've been on antibiotics, they're receiving total parenteral nutrition. And then you start seeing Candida in the urine and other organs. Now, the other challenge in Candida, the other big challenge in candidemias, is the fact that there is epidemiologic trend for particularly in non-albicans. Remember, there are species. It's like staph. There's staph epidermidis, staph aureus, and other staph. So the species that is becoming more prominent, which has increased over the last 10 years, is non-Candida albicans. The main one used to be in the past. 90% of them were Candida albicans. We used to call it albicans because albicans means white. And on a Petri dish, you see it like white ones. And the non-albicans are more the resistant ones to fluconazole. Fluconazole is the key antifungal agent which you can take by mouth. Because of the rise of the non-albicans, the resistant ones, now fluconazole is not as active as before. And I'll show you some slides. The reason why mortality when it gets to the blood is high and it reaches up to this point of around, as we said, around 40% or 45%. The reason why is because the diagnosis is delayed. And many times we wait until the cultures come back. So if you're going to wait until the cultures come back, especially here, they might take quite a bit of time. And then you start therapy. The patient, the patient is, you lose the patient. So we should be able to predict it early at the level of here, either signs and symptoms or risk factors or early antigen at an earlier point. And this is a study by Morel a few years ago, who really has shown very clearly that if you really wait until it's very late, the mortality can go up, attributable mortality, to 35%. But if you treat them when they develop the signs and symptoms within 12 hours, if you treat them early and you know the high-risk patients and you can predict it, if you treat them within 12 hours, the mortality could be here at a level of around only 10%. If you wait a little bit longer, it goes higher to around 26% if it is less than 24 hours. More than 24 hours, you're starting to get to 30% and above. So please keep that in mind, that the earlier you start therapy, the better off you are. So how can we predict it? How can we start early? Well, Leon and colleagues in a study in critical care medicine, CCM is critical care medicine, really found that the Candida score of 3, if you put a scoring system, you can predict it. For example, if somebody does abdominal surgery, if they do abdominal surgery here, they get one point. Somebody with abdominal surgery, and they become and develop severe sepsis, they get another 2 points. This is add 1 plus 2 is 3. So anything which is 3 and above means that the most likely they have Candida. And this is the time where you should give antifungal therapy. If they are colonized with Candida and they have severe sepsis, what I mean colonized is that, for example, you get it from the sputum, or they're intubated, you get endotracheal aspirate, and it grows Candida. Or you see it in the urine, this is 1 point. And then they develop severe sepsis. These are a score of 3. Then you should start treatment. Don't wait until the cultures come back. Because the longer you wait, delayed therapy means higher mortality. صحيح ولا يعني this is in everything. Early therapy means better outcome. So this Lyon scoring is very, very helpful. If somebody has receiving total parenteral nutrition, and they have had abdominal surgery, these are 2 points, and then they develop sepsis. They become very sick and they have fever and they are septic. And then you go ahead and give it because now they have around 4 points. So all of these factors will make you think that way. Now there is some tests. I was in one of the hospitals, actually in IMC, the International Medical Center, مركز الدولي, مركز الطبي الدولي. They have a big hospital. They told me that they have these tests there. For they found a way, which is an antigen, which really, if you have it positive and you can get it within the same day, then this would highly suggest 16 studies, and it shows that in almost 3,000 patients, sensitivity is 76%, specificity of the beta-glucan is above 85%, and it is a quite useful diagnostic factor. But where does Candida come to the blood? Remember, please, that when you do gastrointestinal surgery, the gut has Candida in it. So the Candida can go into the bloodstream, and it can go into the peritoneum. This is part of invasive candidiasis. So abdominal surgery, somebody who is septic and they've had abdominal surgery, or if they have perforation of the gut, and they have peritonitis, always think of Candida. You need to cover for Candida. Yes, you need to cover for anaerobes and bacteria, but Candida should be kept in mind. And the possibility of candidiasis, invasive candidiasis, and anything that has to do with the gut is very important. The other group of patients where it might be coming from the gut are patients with cancer where they give cytotoxic therapy, particularly leukemia, and so forth. Or patients with graft versus host disease, now when they're doing transplant, bone marrow transplant. All of these situations, they would give cytotoxic agents to the gastrointestinal tract. There would be sloughing of the gastrointestinal tract. The bacteria and the Candida can go through as if you have borders, زي البوردرز مصر وليبيا. You know, if you don't have guards on the borders, the guards on the borders are really the white cells. When you have neutropenia and there is a sloughing, the borders are open, and you don't have حرس الحدود, in the neutrophils, the white cells, they can creep into the blood. And remember, all of these microorganisms outside the bug is okay. In gastrointestinal tract, they're useful. But when they go into the blood has to be sterile. It has a lot of spiritual meaning because the creator is the same. Blood always has to be sterile, has to be clean. You can have bacteria on your skin. This is part of the skin microbiome. The GI, okay. But the blood always has to be sterile. Whenever you have bacteria or microorganisms, candida, then you have severe, what we call septicemia or sepsis. So this is a major source for candida, invasive candidiasis. When you do surgery here, when you give chemotherapy that would slough the gut, and why does it do this to the gut? Because chemotherapy hits multiplying cells, rapidly multiplying cells. And the gastrointestinal tract is a rapidly multiplying setting. The other source, which is an area that I've specialized in, I've done a lot of studies in, is the central venous catheter. So when they put the central venous catheter, there is a possibility that will introduce microorganisms through the central venous catheters. Remember, 20% of the medical personnel working in the ICU or in high risk are not only contaminated, their hands become contaminated, colonized with a bacteria like Staph aureus, but 20% have candida on them. And every time they open, if they don't wash their hands or clean their hands, every time they play with that catheter, they introduce the candida into the candida into the catheter and into the bloodstream. So, given all of these factors, what is important in the outcome is what was we mentioned. What really would make outcome worse is delayed antifungal therapy. Early antifungal therapy would improve outcome. Delayed would worsen outcome. We already established this. I showed you the study by Morel. The other thing is delaying the removal of the catheter if it is the source. Thank you very much. This is very tempting to put water for me here. But it's delaying the removal of the catheter. Because if the catheter is a source, this is removable. This is why with catheter-related candidemia, if you remove that source, which is the catheter, outcome is improved. But unfortunately, if it is the gut, you cannot remove the gut. You have to depend on early treatment. But these are two independent factors that would determine improved outcome or worsen outcome, which is either the removing the source for the candidemia or the starting early therapy. Now, this is another big study that only the CDC, Center for Disease Control in the United States, can do. They looked at 4,515 patients, hospitals. They had hundreds of thousands of patients. And they looked at the causes of bloodstream infections among CLABSI, which is central line associated bloodstream infection. The ones that had almost 40% of all candidemias, it's coming from the catheter. And they found among the ones that are coming from the hospital, among all central line associated bloodstream infections, the third one is the ones caused by candida. And it's even more frequent now than Staph aureus. But particularly if there is speciation, Candida parapsilosis is among the number one of those. Now, we devised, based on studies that we have done, what is the best way to find out if the catheter is a source versus the gut. Because it's a microorganism in the gut, you cannot tell. They've had abdominal surgery. They've had post-chemotherapy. How can you tell? But is it the catheter or the gut? There is a way to tell. When they become septic, they become sick. If you draw blood cultures, one blood culture from the catheter, another blood culture, you draw it from the peripheral vein, one from the catheter, central venous catheter, and one from peripheral vein. If the one that you have drawn from the peripheral vein, you try to draw them within 15 minutes of each other, simultaneous, we call them simultaneous. Within 15 minutes, it's like simultaneous blood cultures. If the one that is being drawn from the central venous catheter becomes positive at least 2 hours before the peripheral vein, then this is line related. And this is the one that we have shown as a very simple technique. We call it the qualitative differential time to positivity. Now all labs, most of the labs, I think even many of the labs in Egypt, they have the automated system. Initially they tell you, no, we don't have that thing, but all what they need to look, when did the blood culture become positive? So if you draw from me today, simultaneous blood cultures, one from the central venous catheter, one from peripheral vein, and you check in 2 days, they are both positive. You ask the person in the lab, Ya when did this become positive? We're like, no, I don't have the information. I said, look at the machine. They look. The one that was drawn from the CVC, the one that drawn from peripheral vein, became positive, let's assume, at 10 a.m. in the morning. The one from the one from the CVC became 10 o'clock in the morning. The one from peripheral vein became positive at 1 p.m. in the afternoon, 3 hours difference. With the CVC being earlier, you say this is line related. Because anything more than 2 hours where the one is coming first is the catheter means that this is catheter related. So you do a little math, it's a little formula, and then you can figure out. If it is so, if it's the catheter, you remove the catheter. The reason why, if it's the catheter, you remove the catheter, if not, you keep the catheter. In this big, huge study, we published it in Clinical Infectious Disease Journal, which is a leading journal, we found that by multivariate analysis, removing the catheter within 72 hours, there is a very significant difference in terms of response and outcome in favor of removal of the catheter in those patients that are definitely line related based on these criteria. Catheter related. And those that are not catheter related, it doesn't make a big difference. So these are some of the very important elements. Now, what is the treatment? I think, I don't know how many of you use amphotericin, but amphotericin B is the traditional treatment that used to occur. You give amphotericin B and usually it's 0.5 milligram per kilogram per day. But it's very toxic. We used to call it the amphoterrible. Outpatient? Die. Yes, because it's very toxic and it can cause hypokalemia, hyperkalemia, fever, chills. We used to call it amphoterrible. It's like chemotherapy, it's even worse. They start having rigors, not only from the candidemia, but from the ampho. And then something happened almost 20 years ago based on this large study, multiple large studies. We found that fluconazole could be as good. Fluconazole is like a good antibiotic, minimal side effects, excellent safety. You can give it IV and you can give it oral. Amphotericin B, you don't give it oral. And it's a good oral absorption, prolonged serum half-life, crosses blood-brain barrier, minimal toxicity. So it really became the standard of care. Now even for the oropharyngeal candidiasis, the vaginitis, fluconazole is the drug of choice. But even systemically, you can start IV and then give them a higher dose to complete 2 weeks, and they do very well with candida. So now fluconazole is the standard of care, particularly for candida albicans. And it's based on this study where they compared amphotericin B IV, 79% response was equivalent to fluconazole 400, which was 79%. And this became the standard of care for the last 20 years, for almost the last 15 to 20 years, giving fluconazole in patients with candida in the blood, in such patients. And you have to complete 2 weeks, 2 weeks total. Okay, so what happens now is we've overused fluconazole. We started giving it prophylactically to patients that are high risk, patients with cancer, patients with neutropenia, patients in the ICU even. It became like we offer chocolate here in the Middle East. So everybody, you gave it to your friends and your foes. And this caused selection of resistant organisms. We started seeing these other species that are resistant to fluconazole emerging and becoming leading organisms, mainly the Candida glabrata, because albicans remain very susceptible. The resistance rate is only 1 to 2% to fluconazole. But then we started selecting for these resistant organisms. And this is what happens when you abuse antifungal agents. Sorry, you have a question? Here? Okay. Skin. So they put it on the skin? They give fluconazole. Oral. So, so there is overuse of fluconazole. And this one, there has been a selection for glabrata and cruzii that are the resistant ones. And this applies to everything, even antiviral agents. Now, there are resistant organisms to Sovaldi. For hepatitis C, they overused it. They used it as a single agent. So you always have to be thinking of second generation. Sovaldi means sofosbuvir for hepatitis C. We use cephalosporins so much to the extent we created MRSA, methicillin-resistant Staph aureus. So now, unfortunately, we had to look for other agents. This is like at MD Anderson, in patients with hematologic malignancy, because we used so much fluconazole prophylactically for years. We published with Ray Hashim in Cancer, a leading journal, we published that glabrata became the leading cause, which is resistant to fluconazole, the leading cause of candidemia, followed by Candida krusei. And this is true across the board. Another agent, another organism, but this is very latest. We're talking, these are reports from 2016 and 2017, a few months ago. And now we still see some reports. Is Candida auris. Now this is not Staph aureus, this is Candida auris. And then you have, this is the latest news. تعرف خبر عاجل, like this is like خبر عاجل, you know. This latest report. Candida auris is also emerging as a very serious organism which is resistant to antibiotics and antifungal agents, particularly fluconazole, and even amphotericin B. The first time we're finding resistance up to 35% or 39% to amphotericin B. It occurred in South Korea, first report in Japan, in India, in South Africa, in Kuwait, and even it would be existing here if we look for it. It's all over. Pakistan, Venezuela, and even in the United States, there are alarming numbers, exceeding numbers in New Jersey, in New York, and so forth. And the number of, for example, when they looked at the first 54 patients from around the world, look at this. 41% of them, they were already on good antifungal therapy. And it occurred, it broke through. And the other big challenge here is that many of them, more than 60%, had bloodstream infections. 93% of them are resistant to fluconazole. And 35%, almost 1/3, is resistant to amphotericin B. So this is the challenge with this newer agent. And 59% of them died, 60% mortality. So this is why one has to be now concerned about these resisting organisms, although to fluconazole, glabrata, tropicalis, krusei, even Staph aureus, even Candida auris. The other thing, a newer agent, I don't know if it does exist here, is the liposomal amphotericin B. They put the amphotericin B in a liposome, which is a lipid formulation. And they've shown that it does decrease the risk of nephrotoxicity. Rather than half of them having renal damage, it's one third, half of them, 49%, it's 1/3, 29%. But this is like, I call it زي الأعور بين العميان, you know, have you heard that saying? Like it's true, not half of them are getting nephrotoxicity, but 1/3 of them are still getting. And they charge so much for it. So people started using this as a still second line of defense. And the azoles are the better drugs. Now, there is no doubt that liposomal amphotericin B has equal or maybe slightly better efficacy and less side effects than amphotericin B, the lipid formulation of amphotericin B, but the expense, the cost, the product cost is tremendously much higher. And it's even in the United States, it's like almost $800 per day, whereas amphotericin B, it's around $50 per day. So tremendous increase in cost. Itraconazole doesn't offer much help with these resistant candida, so itraconazole is not the help. A newer agent, but it's a relatively expensive one, which is more broad spectrum and covers not only candida, but the other fungi like aspergillus and immune compromised, is voriconazole. But voriconazole is a good agent for things like aspergillus. And these aspergillus, which is mold, تعرف المولد البنسيليوم يجيبوه من البنسيليوم, right? But it's like the mold, but it causes pneumonia rather than bloodstream infection in immune compromised patients with neutropenia, leukemia, transplant, solid organ transplant, lung transplant. This is what, and the drug of choice there is voriconazole. It is also active against candida, but we don't use it for candida much, but it is active against candida. The agents but is very active against aspergillosis. And this is the drug of choice for mold infections. Voriconazole is also very useful for things like onychomycosis or nail dystrophy. It's a useful drug, but it's an expensive one. Like fluconazole, it penetrates. This is a study that shows in candidemia it's as good as amphotericin B because it's broad spectrum, but at much lower side effects. These are the side effects here. Less and lower number of side effects with this newer agent. But the great agent, the best agent for candidemia and candidiasis are what we call, and they act against the cell wall. They are the echinocandins. And I don't know if you heard of them, but there are three types of them. Caspofungin by Merck, anidolfungin is by Pfizer. And micafungin is by a third group, Astellas. These are the agents that really work very well against candida. Unfortunately, they are only available intravenously. But they have all been shown to be excellent. In vitro activity, anything less than 2 means it's very susceptible. And as you can see them here, they're excellent against all species, even the ones resistant to fluconazole. The caspofungin is the same, the micafungin is the same. All of these echinocandins, they all start with fungin at the end. They are all very active against candida, and particularly candida in the bloodstream. They're also very active against the oropharyngeal candidiasis, the esophageal candidiasis in immune-compromised patients who failed fluconazole. So this is the advantage. And if you look at the studies that they are out there, you find the first study by Maura Duarte in the New England Journal of Medicine, which is more than a decade ago, showed that it is better than amphotericin B for candidemia, but safer. Micafungin and caspofungin are the same. The study by Reboli shows in the New England Journal of Medicine that it's even better than fluconazole, the anidolfungin, the third one, which is Ecalta here. And when they compared it to fluconazole, it was on the end of therapy here, it was significantly better, almost 20 points difference in terms of the anidolfungin being superior, and it was even against Candida albicans, it's more potent. So it is a drug of choice in these situations, and it's even safer. Fluconazole is safer than amphotericin B. This is even safer than fluconazole. Less hepatotoxicity, or toxicity to the liver. So it's a very potent agent, and it's the agent that you can use in patients that are high risk. This is a study where they've used it in patients who are elderly, patients and critically ill with invasive candidemia, and the results were very outstanding. They are elderly patients above 65. They had higher scores of severity of illness, and when they used this, the outcome was really an outstanding one. Now, IDSA 2009 guidelines, this should be actually 2016, also the same thing. When to use these agents, the drug of choice to use is, when unknown, is to use an echinocandin, either caspofungin or the anidulfungin. It's important to have that. An echinocandin is favored for patients with moderately severe illness and who have had recent exposure to some sort of azole prophylactically. Or they are in a hospital where you're seeing more of glabrata, which is resistant to fluconazole. You can use fluconazole as a treatment for patients who are less critically ill and who never have seen fluconazole before or an azole before. And Vori can be used in some situations only, particularly as a step down. For example, if you have C. glabrata, you start with an echinocandin, caspofungin and anidulfungin, and by day 6, they are better. To complete 2 weeks, you move them to voriconazole rather than anything else. And as seen here, fluconazole in the less critically ill, you start with loading by 800 and then 400 Q daily. The ones that are moderately severe, it's caspofungin, micafungin, and anidulfungin are the ones you use. Are these three equivalent? Yes, they are equivalent in terms of efficacy. The advantage for anidulfungin is mainly a better volume of distribution, a longer half-life, but the most important one is this. In anidulfungin, if they have renal failure on hemodialysis, or if they are hepatotoxic, you don't need to adjust the dose. And it makes your life much easier. So you can give the loading dose of anidulfungin of 200 and then 100 every day without any dose adjustment. And that will keep you without worrying about adjusting the dose like what you do in caspofungin for candidemia. This is all what I have, and if you have any questions, I'll be glad to take them. A miracle has happened today because we finished before time, 5 minutes before time. This is to happen in Egypt or in the Arab world is real miracle from on high. Because we started 20 minutes late. Any questions, please? Any? Yes, sir. Okay, if you suspect it, the problem, you have to give treatment, even empiric treatment that is based on high suspicion. What really increases the resistance is giving them prophylaxis for indefinite time of indefinite period. So patients with cancer, they don't need fluconazole unless they have hematologic malignancy, that is leukemia, and they are neutropenic for more than 2 weeks. You see what I'm saying? And some people give them voriconazole because it covers mold, the aspergillus. But these are a small subset of all cancer patients. Patients with breast cancer, patients with a solid organ transplant, ovarian cancer, uterine cancer, colon cancer. Even when they get chemotherapy, the neutropenia period is less than 7 days. You don't need to give them fluconazole then. Empiric treatment, not prophylactic. Empiric treatment recommended when you suspect it. But don't give prophylaxis for people who don't need it, low-risk patients. because then you develop resistance. But you can give prophylaxis to only the few who need it. That is leukemia patients, acute myelogenous leukemia, not CLL, acute myelogenous leukemia, or patients with transplant, for example, pre-engraftment. You give them prophylaxis. Or patients, please go ahead. Yeah, constant fever, if they are not in the ICU, it's not caused by candidemia. Oh, leukemia, if they have fever, yes, consider it, yes. The plan with leukemia patients and neutropenic, if they develop fever, we call it febrile neutropenia, immediately you have to give them antibiotics. If they don't respond within 48 hours, 48 to 72 hours, actually 72 hours is when everybody agrees based on the guidelines, then you give them antifungal. And the best antifungal is one of the echinocandins, because they are sick. Yeah, you don't use fluconazole there because they might have the other candida, الوحشين, the other candida, so you give echinocandins. Yes, sir. Sinusitis, oh, okay, very good question. So fungal sinusitis, the fluconazole, because usually these are caused by mold, not candida. So you have to use an agent like voriconazole, VFend, which is available oral, and you can give it for fungal sinusitis. Time is 2 weeks. Yes. It could be longer in immune compromised. If they are immune compromised, then you have to give at least 4 to 6 weeks, at least. Sometimes we treat them for a month. Huh? No, at least 4 to 6 weeks. Otitis media, an immune competent, we're talking about 2 weeks. And then you reevaluate. مع antibiotic? Yeah, you can use them together. إذا مش عارف. Yeah, you suspect it, but. And you don't want to give them all together. If you suspect it based on what the cultures would show. But if you suspect it, I usually start with antibiotics. If the patient is improving, yes, I will go forward. And then the cultures would come back 5 days later, 4 days later, 6 days later. If there is fungus, I will give the antifungal then. Yes, sir. No. You see, when it becomes very invasive, if it's fungal candidiasis, the most common cause is candida. And there you have to treat, this is one of the indications for surgery plus a prolonged therapy. And the prolonged therapy, there depending on the species, we're talking about 4 to 6 weeks. You would err if it's in the left, if it is a mitral valve, or if it is a aortic valve, then you have to talk about 6 weeks. Now, if it's albicans, you can treat with fluconazole. If it's non-albicans, then you have to treat with echinocandins for 6 weeks, which becomes very expensive. But you have to consider surgery in that situation, because the risk of emboli from the lungs with candida is very high. Yes, sir. Yes. Yes. Very difficult to treat, very difficult to treat. But you need prolonged therapy. Usually if we're talking about candida, because candida osteo is one of the leading causes. Now other mold can give you osteomyelitis, as you well know, Fusarium, other things. But if it's candida, you can treat, partly you don't have to treat IV all the time. But you can treat for like 2 months with oral, but you have to use a high dose to penetrate. Like fluconazole, we're talking about 400 milligrams to 600 milligrams per day. With fluco? No, No. Actually, the good thing about fluconazole, it's a safe drug. You have to follow the liver function tests every 3 weeks or every 2 to 3 weeks, but it's relatively safe. They can take it once per day. So if you give them 3 tablets of 200, like 600, if it is bad osteomyelitis, then they take it all 3 tablets together. What is indicated by the FDA is 2 tablets of 200, which is 400. And that you can give 4 to 6 weeks easily. Mucormycosis. Okay. Mucormycosis is a very difficult to treat infection, and I'm very glad you asked the question, because it fails. You cannot treat it with fluco. It's resistant to fluco. It's resistant to wadi. So you're out of. It's resistant to the echinocandins. The only ones that you have is amphotericin B or liposomal amphotericin B, and these are either expensive or very toxic. The best agent to use is to use posaconazole. But in the beginning, you have to use a combination, if it's invasive mucormycosis, especially in diabetics, of liposomal amphotericin B or amphotericin B plus posaconazole. I don't know if you heard of posaconazole, but now they have it in tablets, and that is well absorbed. And we usually use the combination in the beginning until the patient stabilizes for the first 10 days. They can take the posaconazole oral, and then we switch them to oral for a longer time period. Another 4 weeks of oral tablets posaconazole. Well, thank you very much. There's a lot of interest in fungal infections. Thank you. Yeah.